Hello everybody. Welcome back to the ERMP and Beyond YouTube channel. We have been discussing in the last video on the 2021 ERMP recall questions. Today we will continue our discussion from question number 2 to question number 5. But first hit that subscription button for me. A 19-year-old girl is diagnosed with an advanced hematologic malignancy on bone marrow biopsy. Her hematologic oncologist decided to do whole-body radiation before doing the bone marrow transplantation. Which tissue is most liable for radiation injury? A. Neuronal tissue. B. The gastrointestinal epithelium. C. Skeletal muscle. D. Chondroid tissue. Radiation injury or radiosensitivity refers to the relative susceptibility of cells, tissues, and organs to the harmful effects of ionizing radiation. The sensitivity of different tissues to radiation is taken into account when planning radiation therapy to minimize harm to the patient while maximizing effectiveness of the treatment. Tissues with highly radiosensitive cells may require lower radiation doses to spare healthy tissue. Conversely, tumors with resistant stem cells may need higher doses for effective treatment. By the way, what factors influence radiosensitivity of organs and tissues? The most important factor is the rate of cell division. Actively dividing cells are more sensitive to radiation. Rapidly dividing cells are more vulnerable to the effects of radiation because radiation can cause damage to the DNA during the cell division. The second factor is degree of specialization or degree of differentiation. Cells that are poorly differentiated, or cells that are undifferentiated, tend to show higher radiosensitivity. Less specialized cells, such as stem cells, are more susceptible to radiation damage. The other factor is higher metabolic rate. Cells with a higher metabolic rate are generally more radiosensitive. Well-oxygenated tissues are more radiosensitive. This is because oxygen plays a crucial role in enhancing the effects of radiation. The final factor is length of proliferation time. Cells that spend more time actively proliferating are more radiosensitive. Proliferation time influences their vulnerability to radiation-induced damage. This diagram depicts the radiosensitivity of tissues and organs. While the cells and tissue on the top of the triangle are the most radiosensitive, the bottom of the triangle represents radioresistant tissues. Returning to our case. From the given options, the tissue most susceptible to radiation injury, particularly in the context of whole-body radiation, is the gastrointestinal epithelium. This is because the cells in the GI epithelium have a high turnover rate, and they divide more rapidly than those in neuronal tissue, skeletal muscle, or chondroid tissue. This sensitivity of the gastrointestinal epithelium to radiation can lead to a condition known as radiation enteritis. In contrast, neuronal tissue, skeletal muscle, and chondroid tissue have lower rates of cellular turnover and are thus less susceptible to immediate radiation damage. However, it's important to note that while these tissues may be less prone to acute injury, they can still suffer from long-term effects of radiation exposure. The purpose of the whole-body radiation before bone marrow transplantation was to eradicate any remaining malignant cells and to suppress the immune system to prevent rejection of the transplanted marrow. Third question. A 31-year-old lady presented to OPD with a complaint of right breast lump of 3 months duration. On physical examination, there is firm to hard irregular mass over the upper outer quadrant of the breast. Mammography revealed a 3 by 2 centimeter irregular density with microcalcification. Biopsy demonstrated extensive fat necrosis. What is the most likely diagnosis of this patient? A. Invasive ductal carcinoma. B. Fibrocystic changes. C. Pregnancy. D. Trauma. Fat necrosis of the breast is a benign condition that most commonly occurs as the result of breast trauma or surgical intervention. It's challenging to differentiate between a fat necrosis lump and a breast cancer lump through physical examination or mammograms. Biopsy can confirm the diagnosis, although experienced radiologists can usually determine that a lesion represents fat necrosis based on mammographic and ultrasound findings such as oil cysts. Let's see a mammographic features of breast fat necrosis that help in distinguishing from breast cancer. The appearance of fat necrosis on mammogram is in concordance with the stage of evolution of fat necrosis and ranges from focal asymmetries, architectural distortions, mass-forming solid lesions, cystic lesions, oil cysts, and calcifications. Initially, it may appear as an ill-defined and irregular spiculated mass-like area. Associated calcifications can be present, mimicking those seen in more malignant conditions like ductal carcinoma in situ. Over time, fat necrosis can change, leading to progressive calcification. As a result, comparison with previous imaging is essential. The calcification of fat necrosis is typically peripheral, creating a stippled curvilinear appearance that resembles lucent bubbles in the breast parenchyma. As it evolves, fat necrosis becomes more well circumscribed, eventually giving rise to an oil cyst, collections of liquefied fat, which is a pathognomic finding. Oil cysts may exhibit fine curvilinear calcification of their walls, and the center of the lesion becomes increasingly homogeneous with fat density. The diagnosis of this patient's problem is already confirmed with biopsy, but we are being asked the underlying diagnosis, which we consider as a cause rather than a diagnosis. Given the findings, the most likely diagnosis for this patient would be related to underlying trauma, option D, as fat necrosis is most commonly caused by direct trauma or surgery. Option A cannot be the answer, as invasive ductal carcinoma would typically present with different histopathological features. Option B also is not the answer. Fibrocystic changes are a common benign condition characterized by lumpiness in one or both breasts, but the presence of extensive fat necrosis is not a typical finding. Option C is wrong choice, as pregnancy-related breast changes are not associated with fat necrosis and the described imaging findings. Question number 4. A 37-year-old lady presented to an OPD with a complaint of irregular vaginal bleeding of 3 months duration. Pelvic ultrasound revealed endometrial thickening. Endometrial biopsy confirmed the diagnosis of atypical endometrial hyperplasia. What is the most likely condition that could be associated with this presentation? A. Human papillomavirus. B. Long-term use of IUCD. C. Pelvic inflammatory disease. D. Unopposed estrogenic stimulation. Atypical endometrial hyperplasia is a condition characterized by the thickening of the uterine lining with abnormal cells, which can lead to irregular vaginal bleeding. It is considered a precancerous condition that may progress to endometrial cancer if left untreated. The most likely condition associated with atypical endometrial hyperplasia is unopposed estrogenic stimulation, given in option D. This occurs when there is an imbalance between estrogen and progesterone, with estrogen being present without the counterbalancing effect of progesterone. Several factors contribute to the unopposed estrogenic stimulation of the endometrium. Let's discuss some of risk factors. In obese women, excess body fat can lead to increased estrogen production. The aromatase enzymes in adipose tissue of these obese women convert androgens into estrogens. In anovulatory cycles or in irregular menstrual cycles, the serum progesterone levels remain low, allowing estrogen dominance. Some ovarian tumors, such as the granulosa cell tumors, can produce excessive estrogen and may lead to unopposed estrogen exposure. Women undergoing estrogen replacement therapy without progestogens are at risk for unopposed estrogenic effect on the endometrium. Therefore, these medications should be carefully balanced. Women who have not experienced pregnancy have more menstrual cycles and prolonged estrogen exposure. Similarly, starting menstruation early or reaching menopause late, increases the cumulative years of estrogen exposure. The polycystic ovary syndrome is associated with hormonal imbalances, including elevated estrogen levels. Tamoxifen, commonly used for breast cancer prevention or treatment, has estrogen-like effects. While human papillomavirus and pelvic inflammatory disease are associated with other gynecological conditions, an intrauterine contraceptive device can cause irregular bleeding. They are not typically linked to the development of atypical endometrial hyperplasia. The hormonal imbalance caused by unopposed estrogenic stimulation is the most likely condition associated with atypical endometrial hyperplasia, leading to the thickening of the endometrium and the potential progression to endometrial cancer if not properly managed. Question number 5 will be the final question for today's discussion. A 70-year-old man presented to an OPD with a complaint of right upper quadrant abdominal pain of 3 months duration. Abdominal ultrasound showed multiple discrete subcapsular nodules in the liver. Serum alpha-fetoprotein is within the normal range. What is the most likely diagnosis? A. Hepatocellular carcinoma. B. Cholangiocarcinoma. C. Focal nodular hyperplasia. D. Metastases. Liver nodules or masses can be divided broadly into primary and metastatic, also known as secondary nodules. The primary lesions can be further divided into those of hepatocellular origin and non-hepatocellular origin. The hepatocellular origin category consists of benign and malignant lesions arising from hepatocytes, while the non-hepatocellular origin category includes biliary, mesenchymal, hematopoietic, and vascular tumors. The metastatic tumors spread to the liver from another part of the body. They are also called secondary liver cancer. Common cancers that can metastasize to the liver include ovarian cancer, breast cancer, esophageal cancer, colon cancer, kidney cancer, rectal cancer, lung cancer, endometrial cancer, stomach cancer, pancreatic cancer, and skin cancer. Generally, while primary liver masses are usually cause no symptoms, patients with metastatic nodules present with symptoms such as right upper quadrant pain. On imaging, liver metastases often appear as multiple nodules scattered throughout the liver, whereas primary liver cancers may present as a single mass or a few large nodules. In the given case, the key words that will help us to answer this question are the presence of multiple nodules on imaging and the normal serum alpha-fetoprotein levels. Let's discuss each liver nodules from the given options briefly. Hepatocellular carcinoma is the most common primary liver malignancy. As most primary liver nodules, it often presents with a single large mass rather than multiple nodules. Elevated alpha-fetoprotein levels are typically associated with HCC, but the patient's serum AFP is within the normal range, making HCC less likely. HCC typically develop in the context of chronic liver diseases like cirrhosis and hepatitis. The common risk factors for HCC are alcoholic liver disease, chronic hepatitis B, and chronic hepatitis C virus infection, and other causes of cirrhosis. Cholangiocarcinoma is a malignant tumor arising from the bile ducts. It is more commonly associated with bile duct dilation and obstructive symptoms, such as yellowing of the sclerae, skin, and mucous membranes, dark urine, and pale or acolic stools. Cholangiocarcinoma can cause liver nodules, but it usually presents as a peripheral hilar mass, rather than multiple subcapsular nodules. Focal nodular hyperplasia is a benign primary liver lesion that is composed of hepatocytes surrounding a central stellate scar. Typically, focal nodular hyperplasia is a solitary lesion that is more commonly seen in women. It is often asymptomatic and doesn't raise AFP levels. Focal nodular hyperplasia often appears as a well-defined hypervascular mass on imaging. Metastatic liver nodules are the favorite option in this question. Multiple subcapsular nodules in the liver are highly suggestive of metastatic disease. Metastases can arise from various primary cancers, including breast, colon, prostate, bladder, thyroid, melanoma, and head and neck squamous cell cancers. Bilobar involvement is frequent, and only 20% of liver metastases present as solitary lesions.